Hello and welcome to another episode of the Doctor Lawyer Breakdown, a show with a unique perspective on everything from the mundane to the arcane. I'm Bradford Katie, I'm your host, and I'm joined again today by Dr. Joseph Ramos. Dr. Joseph.
Every time, man.
Dude, I'm excited.
Good to be with you.
I have been dying to figure out which one of these procedures from our last episode you haven't done yet. So that's what we're going to open up the show with today. So you gave us multiple choice at the end of the last episode. Which of these three have you not done? Yep. And I actually got the name pericardial tamponade correct. I was pretty proud of myself.
Yeah, you got the name correct.
I don't remember the one for the bolt in the head. Something cranium, I'm sure, right?
Yeah. So,
and then the last one was the diaphragm rupture. Mm-hmm. So tell us more. Give us the answer.
So with each of these procedures, the lay term bolt in the head, basically like a craniotomy, where you would make a hole in the head, is when you relieve pressure. Mm-hmm. If someone gets pressure in their brain, it starts to push down. If it herniates through the brain stem, they then would be potentially body alive and brain dead.
Right.
And for that procedure, you have to let cerebrospinal fluid out to take pressure off the brain. So what you do is you basically go to the mid-pupillary line, about 2 finger breadths above the eyebrow, and you put a bolt directly in, and you literally drain off cerebrospinal fluid.
Yeah, and I noticed in all three of these, there's a concept of some pressure, right?
Yes.
So I answered B. I said it is the pericardial tamponade. The audience most answer was C, the diaphragm rupture. But what have you not done that you've always wanted?
Oh, the audience is correct.
Let's go.
Diaphragm rupture. The craniotomy aspect with putting a pressure relief bolt, I have done. Emergency medicine physicians have to do that. It's part of your training.
Oh, wow.
And
okay.
You see a lot of head trauma. The pericardial tamponade is the same way. Most often you'll see this with either major trauma or like a stab wound. Uh-huh. And there's damage to the heart and it bleeds into the sac around it, and that puts pressure on the heart, stops the heart from bleeding. So you have to open up the heart sac and fix the hole. Mm-hmm. And that's done very quickly, and I've done that as well. But the diaphragm rupture is much more significant, and that when the diaphragm ruptures from major trauma, the abdominal contents, your bowel, will go up into your chest.
Oh, wow.
And most of the time, though, you can get people to the operating room and do that in a controlled fashion, and that I've not done.
But that's a procedure that one's like, is it high risk, I assume, but
very, very high risk procedure, very difficult procedure, and some of them don't even need to be fixed. The diaphragm, it depends. There's a nerve that goes to the diaphragm that helps its operation, and it depends on if that nerve was injured as part of it or not, and it depends on how big it is, the rupture, and if it's actually trapping the bowel contents.
Very interesting.
Yeah, so it's one you can make some decisions on. It's not, usually seconds to minutes, like the two prior conditions are that we talked about.
Wow, incredibly interesting. I can't wait to pick your brain on more of this stuff. This is awesome. But I have a different subject to pick your brain about today.
Okay, what is it?
So, very topical. AI is everywhere.
Yes.
Right. And we see, there's AI advertisements on the Super Bowl. They're sponsoring, it's everywhere. But has it made it to the doctor's office? So I was thinking, we talk about the zip code, right? Yeah. The intersection of law and medicine. This feels like it's in the zip code. Like, I understand that, offices need to improve, scheduling or note-taking, but how does that interact with a doctor's responsibility to care for their patients? And with the advent of AI, if it's not already in the doctor's office, it will be soon. Let's break it down.
This is a great topic, man. Great topic to pick. In fact, very timely, because I was just at a reunion. We had our 50th, not my 50th, but the 50th anniversary of the Denver Health Medical Center program. The Emergency Medicine and Trauma program was just actually a week ago. So I was there and got to see doctors for generations and generations, all wearing the year that we completed the program.
That's awesome.
And yeah, it was great. I got to see a bunch of my old friends and stuff. But as part of that, it's funny because people were actually talking about AI in medicine. So it's interesting that you would ask about it.
Okay.
And there is no doubt whatsoever that it's having a massive impact on the lives of doctors, on their function, both good and bad. And there is no doubt that there is a legal intersection with AI and doctors' use of it that we will see in the law firm. This is just starting to creep up now. And I think there's actually a third dynamic to this, and it's kind of what the patient experience is going to be like now.
That's what I was thinking too, right? So what I want to start with is, I don't want to necessarily say it's good or bad or it's negative or positive. Let's start just with how doctors are using it. Let's start with that. And then I want to talk about some of the negatives and positives. And then I do think it's important for the audience and for anyone else listening, if you're not a doctor lawyer, how is this going to impact you? So that's kind of the flow I wanted to do for today's breakdown. But let's start with what's being used. It sounds like it's quite fresh in your mind. I had no idea you went to this conference. This is rather timely.
Yes,
but how are doctors using AI right now?
So the most impactful ways to doctors, it started off with the simple stuff. And that's the stuff we don't need to wade into much. And that's taking notes, for example.
Sure.
Doctors can now basically record their visit, train AI to put it in a particular format and put it in the chart.
Okay.
So doctor documentation, which is something that all doctors despise of, is becoming very simple. That's good.
Nobody likes the paperwork, but everyone's got to do it.
Yes, but everybody's got to do it. And that will add to probably the richness of a doctor's life.
Okay.
And so there's some simple things like that. The areas that's probably making the most impact is this. It used to be, if you came to me with, let's just say, chest pain and shortness of breath, the doctor thinks through a differential diagnosis. Oh, could that be pulmonary embolism? Could that be myocardial infarction? Could this be anxiety? Could this be a pneumothorax? Blah, blah, blah. You go on and on through this differential diagnosis, and you may or may not remember every single one of them. Let's say you remember 5 or 6 or 7 things, but it's the 8th. You might miss it. And that would be a missed diagnosis.
Right.
And now you could put into AI chest pain with shortness of breath, and it gives you the laundry list.
No missing.
And then you can put in the patient's age, conditions, coexisting or pre-existing medical history, and it can just narrow it down like that. Same thing with medications. Doctors used to have to look and go, okay, does Coumadin interact with Cardizem, a heart medicine with a blood thinner? Does Digitalis, digoxin that we use for controlling heart rate, does that interact with this antibiotic? We used to, now with AI, bam, medication interactions from severe to mild to back to our black box talking.
Yes.
Our black box talk a few episodes ago. To don't ever do it.
Right.
Now AI is just on that. So instead of before, that would take me a lot of time with a patient. I know with the press of a button.
It's pretty incredible time saver in that aspect.
Big time saver, but if you think about it, a big safety impact for the patients. Because if a doctor had gotten kind of careless and got really focused on diagnosis and treatment, but they forgot medication interaction, now the program does it all for you at once. That is something.
Yeah.
And that's one big area. Here's another big area of medicine that's changing. Let's just say that I wanted to know what the latest research is on, just pick something simple, hypertension, high blood pressure, in a 60-year-old newly diagnosed. What's the leading way to treat them? And I go, well, I think it used to be ACE inhibitors, but maybe it's calcium channel blockers, maybe it's beta blockers. There was this paper I heard about, blah, blah, blah. Now what happens is, and you used to have to read articles. You would pull up the major articles, you would read about newly diagnosed hypertension, you would read about what the leading treatments were and why. Now, AI will summarize all the latest research. You can say, give me the last 5 years of research, or last 3 years of research with newly diagnosed hypertension in a 60-year-old male. I would like this from all of the leading medical treatises. And it'll summarize all the articles in minutes and give you a conclusion as to why you should use which of those medicines.
Wow.
Bam.
Yeah. 20 minutes.
At the max.
Yeah.
So it's really fast for giving you updates on the latest research.
Okay.
So it's a huge research tool.
So we've covered some not diagnostic, but diagnostic. That's the right way to say that.
Yeah, it is.
Right? Okay. So then we've also covered like medical interactions, medical research. I mean, the next thing that comes to my mind is imaging. There's got to be some AI use for that.
There's actually a study out on that. It's funny you'd say that. There's a study that's out. So there's certain fields of medicine that are going to be drastically impacted, and one of those is radiology, in my opinion. And here's why. Interventional radiologists, those are the ones who do procedures.
Okay.
They see a tumor and they want to run a line up to it and inject poison into it. That's an interventional radiologist.
They're in the room doing the surgery.
In the room doing a surgery, usually through a vessel.
Gotcha.
Okay. But there are the radiologists we all traditionally know are the ones that are reading films. You got a CT done, you got an MRI done, an X-ray done. People don't know this, but the great majority of radiologists are not in the hospital anymore. The great majority. In fact, radiologists rarely see the hospital anymore. They're doing the film reading because things have become so quick with data over the internet and images. They can sit at a computer in Mexico.
Yeah.
Where most of them are.
As long as it's got an internet connection.
Yes, as long as you have an internet connection. You can read the studies timely, live where you want to live anywhere in the country, and deliver reports. Now,
Pretty sweet gig, though.
Sweet gig.
Yeah.
But here's the problem with that gig. They actually did a study where they took breast cancer mammography, and they had AI read them and radiologists read them. And they did it where there was a prior film. So the person, people will have their mammogram done annually after a certain age. And there's some gap in there that they may have a year or 2 years or whatever. And they said, we want the other film compared to this film. And they give it to a radiologist, want this film compared to this film. And AI exceeded the radiologist on the ability to find fine details.
Wow. So AI capabilities for reading an image to, like, I mean, I'm kind of thinking of the kids, like, find the differences in these pictures.
Right.
That's kind of literally what it's doing.
That's
and
right.
That's the same procedure that a radiologist anywhere in the U.S. or abroad might be doing as well when they're reading these films. And AI was better?
And yes, and the difference may be that radiologist abroad might be in a hurry to get with his wife down to the beach that day, might be tired from the night before, might not maybe his imaging, maybe he's doing an 18-inch screen instead of a 36-inch screen. AI doesn't need any of those factors. It's not personal like that.
Right.
It's specific to the hair and what's the detailed difference. In your example, what they used to do just when we were a kid, compare the two pictures, what do you see differently?
Right.
That's exactly what it is, and AI is a master at that. Now, it's yet to be seen, can AI read that breast mammography film initially as good as a radiologist initially? I don't believe that's been decided yet.
Okay.
In comparison imaging, AI so far, and it's early, has been pretty superior.
Wow. That's incredible. So, okay, we've talked a little bit about imaging. We've talked about some diagnostics, medical interactions, medical research. We talked a little bit about scribes. I want to shift into the next half of this, or the next section of this, where I'm not necessarily asking you to pass judgment whether these things are good or bad, right? Because it's difficult for us to tell at this point. But there are a couple things that while you were speaking, I was thinking about, right? What is the risk of, let's say, a doctor doing one of these summaries about all the different medical research that's out there, that the AI gives them a misinterpretation of that information? Like, they're using AI to compile this research data, or they're using AI to understand, like, oh, this is how these medications interact with each other. I mean, trust but verify, right? So how is that saving the doctor time when it comes to comparing medicine? Or, it makes me feel like they need to go back and read those special reports anyways.
Right.
So,
yeah, great point. Is it actually taking more time because they're having to go through things twice, or is it taking less time? And what is the risk? And ultimately, here's where this intersection with law comes in.
Okay.
So the doctor is the head of the food chain, if you want to call it that. Is the top of the pyramid.
Top of the pyramid.
And if he chooses to use AI to read the film and go, oh, it said it's normal, or it gave me this 7 items on differential diagnosis, that must be the only 7. And he's wrong. He can't turn around and go, AI said.
Oh, so
if he does his research, and let's just say AI concludes that everyone that has a stroke should have aspirin. Well, that's not necessarily true.
Right.
But AI may have done that because it went and found just particular articles because maybe you queried it wrong, or maybe the search capability isn't out there, or maybe AI is doing what it's been known for now. We're seeing a lot more hallucinating.
Yeah.
They're calling it hallucinations.
Yes,
AI
I've
just
heard
makes
of this.
stuff up.
Yeah, it does. It just makes things up because all it wants to do is give you the answer, and so it'll just make something up to give you an answer.
Right.
Like, that feels like a significant concern in the medical space if this is how the doctors are using this.
It's a significant concern, and the doctor will be liable, and attorneys will be going after them when they rely on AI. Here's the problem. One of the critiques that all my buddies had the other night at this thing we were all visiting is they were like, hey, are residents really learning as much? Are they really taking the time to learn? Because now you can query and you get answers, and you kind of start to get really narrow in your vision when this really smart program is giving you answers. And they may not expand as much as maybe some of the older doctors didn't have all that and had to do all the reading and think way outside the box. So the question is the education the doctors are getting now as good? And are they going to be able to make that determination like, thank you, AI, but I disagree? I don't know that the trend in medical training is going in a way that will occur. I think doctors will start to rely on that. And I think a lot of doctors will get their ships sunk by medical malpractice attorneys like me when they do that. They have a duty to verify and to know.
Because it's not just getting the answer.
That's right.
It's knowing why.
Yeah.
And that's why you go to medical school, is to understand the why we treat the human body in these certain ways, or give it these certain drugs, or do these certain procedures, not just query something to tell you what procedure you're supposed to do.
You're right. And here's the other thing with that. All doctors will talk about that little angel on your shoulder when you walk in the room and you're talking to somebody and they're telling you about their chest pain, but there's something they say and it doesn't line up with something. You go, I wonder if this is the person who's having an aortic dissection and they're a 20-year-old. That wouldn't make any sense. They've never been diagnosed with anything like Ehlers-Danlos syndrome or any sort of cartilage insufficiency type syndromes. But there's something about this that smells that way to me, and you won't know why. We call that the angel on your shoulder. Here's what it is. It's human interaction.
Yeah.
It's listening to the person a step deeper. Just like that's a bad example where it's a bad condition. There are conditions where you're talking to someone and everything sounds like, by all intents and purposes, it's a heart attack or stroke, and you talk to them and you get to realize they're having a really stressful time. They're in the middle of a divorce where their kids just got killed. And you're like, okay, I don't need to run CTs and EKGs and inject people to die and risk their kidneys.
Right.
This person needs a good hand holding, a nice talking to, and you're 100% right. But you get that from that interaction. AI is going to remove that.
Yeah.
There isn't that human interaction, that empathy is going to be gone.
Yeah, especially if the machines like that get leaned on to that degree. That's 100% what it's because it's more efficient to not connect with your patients. Why would I take the time to get to learn why, Joe Schmo's divorce is going and why he's presenting with these symptoms when I could just type something into the computer, give him Tylenol, send him on his way?
Yeah, exactly. Imagine this. Imagine you kind of use that chest pain example. Imagine that for every person who presented to the hospital with chest pain, if they had an algorithm out front through AI that said the most medical legal significant risks are pulmonary embolism and myocardial infarction, heart attack. So here's the panel of labs you run, here's the x-rays you run, here's the studies you run. Person hits a door, they click on boxes, they get sent to different departments. All the results are back. You walk in the room as a doctor and you go, ma'am, your CT scan is normal. You don't have a PE, you don't have a dissection. Your EKG is normal. It's been compared to 3 prior ones. I have it all here because AI can pull data sets from everywhere.
Yeah.
And it gave it all to you. It had all the blood results there. Was that good or bad? The patient, to some people, might go, man, that's great. My ER visit that used to take 6 hours took 2.
Yeah.
To some patients, they might go, the doctor didn't even hear a word I said. My chest pain has nothing to do with either of those conditions. I got hit in the back with a baseball.
Right.
You see what I'm saying?
Yeah.
And so there's not that thinking there, that personal interaction. And I think that there'll be all kinds of downstream stresses that come from that. Patients not being heard, that's who sues, talk about the legal side of this. What we see here in the law firm is that doctors, and this is proven, by the way, in studies too now, but I see it firsthand. Doctors who communicate with their patients don't get sued, or rarely. The patients are understanding if you make a mistake and you say, I didn't see this, I didn't expect this, this was different, that was different, you give them your perspective. It has been shown time and time again, people don't want to sue a doctor who cares. How do you know if a doctor cares? Because he talks to you, he approaches you, he explains. Will lawsuits go through the roof with this? Because there'll be tons of mistakes.
Oh, absolutely.
Will lawsuits go through the roof because there is no personal interaction? Potentially.
It's really interesting to correlate those two things, right? Because there's 2 steps of correlation, right? The first one being less communication, more lawsuits.
Yeah.
More communication, less lawsuits.
Yes.
More AI is going to, what we believe it could reduce the amount of communication, which means you're going to see more of those mistakes. And you could see more doctors coming under legal scrutiny and legal duress for making a mistake, not communicating and not connecting with their patients in the way that maybe they are called to do by their profession.
That's exactly right. And I think that AI is trying to take, you always hear about the art and the science of medicine. And the art is that human personal interaction.
Right.
And the science is the line by line fact of sodium is supposed to be from 139 to 144.
Right.
Yeah. And you're seeing it lack the ability to do the art, but be very good in many ways on the science.
And science is all about efficiency, and you can't rush art.
Well, yeah, and I'll tell you, here's another thing too. You talk about efficiency and talk about not rushing the art part of it. There will be some areas that it will, see, I can say this without confusing the audience, it will improve the science side of the medicine. Let me give you just a quick example. There are never events in medicine. Okay, and what these events are is a person in the hospital should never fall.
Of course.
They just shouldn't fall.
Yeah.
Premises should be kept clean and appropriate. There should be no slick surfaces. Anybody who has a balance or a gait disturbance should always be watched or have assistance, bedside assistance. Anybody who has an injury or something that may prevent them from walking appropriately, or a brain injury or whatever, should always have assistance. They should have a call button. Falls are never events. They should never happen. Bed sores in nursing home patients are never events. They should never happen.
Right.
With proper turning, proper positioning, proper padding, proper attention, proper cleaning, there should not be a bed sore. It's a never event. Imagine, though, if you studied bed sores that occurred and you said, we noticed that everybody that they occurred in, we did what we thought was proper, which is what they always say when you sue them.
Of course.
Yeah. Imagine if they said, well, we noticed they all had oxygen saturations of 92%, 90 to 92%. Everybody had an oxygen saturation above 92, actually never got a bed sore. And we also noticed it in people that had a body mass index or a weight below X number. Maybe something to do with their padding, their body padding.
Right.
Tissue padding.
Not the bedding. Right.
Yeah. So what would happen, 90, 92% might be a perfect oxygen saturation. It might be normal. But maybe a little bit of super oxygenation, a few more percentage points of oxygen might cause better tissue perfusion, which might cause a lower number of bed sores. Did you follow that?
Yes. Yeah.
So better oxygen perfusion, because you got oxygen added, say, when you didn't even need it.
Right.
Resulted in less bed sores. Right now, we can't tell that. To do that study might take years.
Right.
And then we're dependent on people to track. I can query AI, have it run every chart in my nursing home for the last 10 years who had bed sores, pull all their vitals instantaneously and tell me what their oxygen saturations were, pull all their BMIs up and tell me what their body habitus was, and give me if there's a risk factor there for bed sore.
And project into, okay, my current patients, how many of them fall into the risk category, and what do I need to go do to reduce the risk that this never event occurs?
That's exactly right.
Now that sounds incredible.
Yeah, what if you start then putting oxygen on normal people who are in nursing homes who have an oxygen saturation of 92%, but you put them on it because 94%, nobody gets a bed sore.
Yeah. Now, obviously, these numbers are made up, right?
Totally made up.
That's not
that
necessarily
whole situation. Yeah.
But the concept of using a powerful system to be able to show you those kind of data trends, that's incredible.
Yeah, and that's where AI trends towards the science.
Right.
And
this. You're increasing your ability to do what would normally take years to complete a study in, maybe a couple afternoons.
That's right.
So there's two things I want to wrap up with.
Okay.
The first thing is, should the average patient be concerned about any of this? And what should an average patient know or think about when they go to their next doctor's appointment and how it interacts with AI? I mean, it kind of sounds like it's business as usual, and you just need to stay vigilant and talk to your doctor.
Yeah, well, there's a few things I would advise patients on. The first thing is number one, know that all of your doctors are using AI in forming their differential diagnosis and their treatment plans.
Okay.
Make certain, once you know that, because you do know, I'm telling you.
Okay, so this isn't like a maybe thing. They're doing it. It's happening.
It's happening right now.
Okay.
Make sure that you mandate communication with the provider. Make sure the provider's hearing you, not a computer. Because ultimately, to get anything out of AI, you have to query it.
Right.
You have to ask it something. The doctor, if he's not listening to you, can't ask the right questions and you can't get the right answer back. Now your risk of a bad result goes way up. And the truth is that some doctors are not very good communicators. In the future, imagine, hypothetically here in the future, if admission to medical school wasn't based anything on GPA or test scores, it was based on communication ability.
Probably have a few less people admitted.
Yeah. I'm telling you, the communication is going to be that important.
Yeah.
If everybody can be the 4.0 student, if they just communicate well. you don't really need the guy who's number one in his chemistry class.
I see what you mean.
Yeah, so I think that make sure if you're a patient, make sure you know it's being used, make sure you know your doctor's hearing you and you're communicating well, because if you have a doctor who's a poor communicator, you're at a much higher risk of a complication, and then you're at a much higher risk of having to seek out somebody like myself.
Okay, so the two items to take away are, hey, it's happening. They're using it. Differential diagnosis, your doctor down the street is using it to put it together. Highly, highly likely.
Yep.
Second thing is mandate communication with the provider.
Yes.
Okay, so that's kind of a fancy way to say, make sure you're talking to a human. Make sure you're talking to somebody.
Yep. Let me give you one last thing.
Okay.
I know we have to go, but I have to give you one last thing.
Yeah, one last thing.
Because there's a frustrating thing for patients that they always called the hospital on, always called my clinic on, always, as their billing. And there's no excuse for billing errors anymore in medicine. Because there are reams of papers that you used to have to go through to find billing codes and billing numbers and visit dates and CPT codes and ICD-9 codes. And it was just number jargon to figure all of that out. And there was people hired to do it, and doctors are trying to do it. And those days are over.
Okay.
AI can search billing records and find inconsistencies, duplicate billing, missed dates of service where there wasn't billing. It can see if ICD-9 and CPT codes line up. Patient frustration with billing should disappear with AI.
So have a higher standard for the way that your bills are organized as a patient.
Absolutely.
Demand higher standards from your medical provider when it comes to billing.
Yes, and it shouldn't take weeks to get. It should take a day.
Okay.
Boom.
So if you're hitting the 48, 72-hour mark, somebody better be getting an earful about some organization of the numbers.
That's right.
Okay.
That's 2 seconds.
Those are 3 great takeaways.
Nice.
Yeah. Good. No, that's awesome. And I know we're running a little long, so let me get to our sign off. But I want to say this is a super exciting topic. I'm really excited to see how this evolves. I mean, when we come back to this 6 months or however long down the road, I'm sure something's going to change. We're going to have to break this down again with AI moving as fast as it's been moving. And I can't wait for the opportunity. This has been awesome.
Cool.
Okay, last quick question. I wanted a fun story from you today for today's sign off. I know you're a pilot. Yeah. What's the craziest thing you've seen in the air? Give me something crazy. Like, what's the craziest thing you've experienced while you're up there? Right? I mean, I'm guessing you don't have little green men waving at you, but hey, maybe not. Maybe you've got one of those stories.
So many cool things. There are so many cool things that happen while flying. I'll give you one that freaked me out for a moment.
Okay, perfect.
One day I was flying over New Mexico. I'm at about 27,000 feet. And all of a sudden, I have a glass cockpit. They call it basically computer screens in my airplane that I'm flying the airplane off of. I got it on autopilot. And I lost all GPS function. GPS from the satellite goes down to these, helps the plane fly on autopilot. I all of a sudden had no GPS function. So I called into center. I think I had to call like Salt Lake Center or Albuquerque Center. You call the major airline hubs from the air because you're usually communicating with them. And I had radio function, thankfully. And I said, hey, I just lost all my GPS, direction, everything. So I'm not going to declare an emergency. I'm going to hand fly the airplane, but just know I don't have this. They go, oh, don't worry about it. It'll be coming back up in a few minutes. The military's out there blocking stuff right now, running some tests.
Holy cow.
I was like, what? They can do that? They knocked out all my GPS function like that?
Yeah, seconds and just dark.
Yeah, it makes you realize the power of satellites and what we do every day, even in flying.
Wow.
And how quickly it was like, whoa.
Just lights off.
Yeah.
Just like that. Like you're turning them off in the bedroom.
That was a pilot story.
Wow.
Yeah.
Hey, well, I'm going to have to get a few more of those out of you because I know there's plenty of fun little tidbits like that we can do. But that's all the time we have for today. Thanks for joining me again. Always a pleasure.
Enjoyed it. Thank you.
And thanks to the audience as well. Appreciate you all tuning in and listening to another episode of the Dr. Lawyer Breakdown. We'll see you next time.